Hello, I'm Dr. Michael Steinberg from the Department of Internal Medicine. Today I'm going to be talking to you about the pulmonary examination, the exam of the lungs. Here is what I hope to accomplish today. First, we will start with a short discussion of the pulmonary history, including the most common symptoms and some medical terminology that we use to describe and document them. Then I will spend the rest of the time reviewing and demonstrating the pulmonary exam. This is the complete or extended exam, not just the part of the exam that is included in the core physical exam. Along the way, I will discuss some ways that we document our findings on the pulmonary exam, some of the terms and phrases that we use, for example. First, some context. The pulmonary exam is one of the most frequently used organ exams across many specialties, age groups, and a wide variety of clinical encounters. Here are some reasons for that. We use the pulmonary exam to assist in the diagnosis of respiratory tract infections, such as pneumonia and bronchitis, which are quite common. Next, there are several chronic diseases and conditions of the pulmonary system that are very common and for which this exam is fundamental, such as asthma and COPD. The functions of the heart and lungs are highly interrelated. In addition, their circulations are in series with each other, and they occupy the same real estate location in the thoracic cavity. Thus, the exam of the lungs is often a window into heart problems, such as congestive heart failure. The lungs are also a site of a common malignancy, primary lung cancer, but they are also a common site of metastases, or spread of cancers that are outside of the lungs. The pulmonary exam may be the first place that these are detected. Postoperatively, even for surgeries that are distant from the lungs, there are some very important surgical complications involving the lungs, such as pulmonary embolism, pneumonia, and collapse of part of the lungs. Lastly, although there are many good radiographic tests that can be done on the lungs, these are not always convenient to us or readily available. They also can be expensive and, in the case of CT scanning, can involve radiation exposure for the patient. So, for all of these reasons and more, it behooves us to be able to get a good pulmonary history and do a good pulmonary exam. First, let's start with some points about history taking as pertains to the pulmonary system and its disorders. The main or cardinal symptoms of lung disorders are shortness of breath, pain or discomfort in the chest, and cough. Though patients will describe their symptoms as shortness of breath, we commonly use the term dyspnea as a synonym for this in our medical documentation or reporting of shortness of breath. In addition, we like to further clarify a patient's report of dyspnea with details, for example, about when it occurs, with exertion, at rest, both at rest and with exertion, and then with how much exertion. In addition, there are two other subcategories of dyspnea. Orthopnea, which is dyspnea that appears or worsens upon lying flat, and paroxysmal nocturnal dyspnea, which is dyspnea that wakes people up at night, often in a dramatic fashion. These were, and still are to some extent, considered symptoms of congestive heart failure, though certainly other disorders can also cause these events. Cough is self-explanatory. Try to elaborate on the cough to determine if it is a dry cough or if it is productive of sputum, and if so, whether it is discolored or clear. Hemoptysis is the presence of blood, even small amounts such as streaks or flecks in the sputum, and we often ask if this is present. Chest pain or discomfort in the chest with respect to pulmonary problems can occur anywhere in the thorax, even the posterior or lateral areas. As with any other pain that we are working up, we try to ascertain the 7 essential parameters of pain. One special type of pain in the chest or thorax is called pleuritic pain. This is pain that worsens with respiration, particularly with breathing in, as well as coughing. It tends to be a sharp sensation as well. We will often ask about these types of details, pain with breathing, for example, and if the pain seems like pleuritic pain to us, It may point towards certain diagnoses and away from other diagnoses. There are some other symptoms that may be reported by patients or their families. For example, wheezing, a noisy musical whistling sound with a pitch, or apnea, which is the cessation of breathing, as can occur with sleep apnea, or with apnea of premature newborns, or cyanosis, which is a bluish discoloration of the lips, tongue, tips of fingers, and which might indicate lower levels of oxygen in the blood. All of these can be symptoms of pulmonary disorders as well. There are other important things to ask about when pursuing an evaluation of pulmonary problems or symptoms. For example, in the case of asthma, it is important to ask about a family history of asthma or allergic disorders, such as hay fever or eczema, and to ask about smoking or exposure to secondhand smoke, as well as other respiratory irritants. Other details from the history of asthma and other common pulmonary conditions are shown on this slide. Obviously, as can be seen, detailed smoking history or exposure to tobacco smoke is very important for many of these. Now, on to the physical exam of the pulmonary system. There are two major aspects to the pulmonary exam: assessment of the patient's breathing effort and auscultation. And then there are a series of other procedures that are done to clarify or confirm findings. In the case of young pediatric patient, or some other situations in which a patient is unable to cooperate much, the exam is usually limited to just the assessment and auscultation. That is all you'll be able to do. Normally, breathing is automatic, effortless, and noiseless. Our normal respiratory system also allows us to speak comfortably in full or even run-on sentences, such as the one I'm using now. If someone has disease or dysfunction of the lungs, however, this ease may not be the case. Let's look at a short clip. In this case, the child is struggling or laboring to breathe. We see extra muscle use, such as the use of abdominal muscles to assist with exhalation, the neck muscles to assist with inspiration, and the retraction or indentation of the intercostal muscles between the ribs. There is also an increased respiratory rate, and there are other features that suggest a problem. Obviously, the patient is not breathing comfortably and effortlessly here. In such cases, we use descriptive terms to describe this situation. We say the patient is in respiratory distress, or that there are labored respirations with accessory muscle use. Some even use the phrase, there is increased work of breathing. Your assessment of the patient's respiratory effort begins as soon as you open the door or pull back the curtain to meet the patient. This is essentially something that you do while you are taking the history and during the exam, and does not require any special techniques. In addition to the patient's work of breathing, you can also note his or her color, whether there is cyanosis, for example, and whether there seems to be any pain with breathing. The assessment of breathing status is extremely important, since an abnormal respiratory effort often implies a more serious or urgent situation. When breathing seems normal, we often state that the respirations are unlabored, or comfortable, or relaxed. I will now move on to the other techniques of the pulmonary exam. One thing to keep in mind, however, is that there is a simplicity about the lungs that makes the exam not too difficult, at least compared to some other organs. The lung is basically air-filled and, during breathing, moves air along airways into and out of the thorax. So the basic objective of the exam is to determine if an area of the lung is still air-filled and if there is normal movement of air with breathing. As we will see, when the air in a particular lobe has been replaced with fluid, solid masses, or inflammation, it will change what we hear and feel. First, let's start with some surface anatomy, which will help us when we start examining the chest. Here is a projection of the trachea and main stem, right and left bronchi. The trachea branches at the carina, which is located at or just below the sternal angle, which is the joint between the manubrium and the sternum. You can often feel this as a bump on your chest as you palpate from the sternal notch down the sternum. The right mainstem bronchus is larger and comes off at a gentler angle, a point which explains why when small things are aspirated into the lungs, they more often end up on the right side. Here are projections of the lungs onto the chest. A few important points. The lungs do extend above the clavicles. This is important to know in that penetrating injuries to the neck or surgeries involving the neck can cause lung injuries. Looking at the approach from the front, the right or upper pectoral area overlies the right upper lobe. The lower pectoral area on the right overlies the right middle lobe. On the left, there are only two lobes. Most of the front is overlying the left upper lobe. On both sides, small sections of the lower lobes wrap around the lower lateral parts of the chest bilaterally. Looking posteriorly from the patient's back, most of the posterior thorax is overlying the lower lobes, with the exception of a small section near the top, on the upper trapezius area, which overlies the posterior sections of the upper lobes. Let's keep these anatomic relationships in mind as we perform the exam. They will help us to know what part of the lung, in general, that we are examining at a particular spot. Now, on to auscultation. This is the term for listening with the stethoscope. This is what the first stethoscopes looked like in the early 19th century, a single tube to be placed on the chest. Prior to this, physicians would actually place their ear onto the chest wall to listen to breath sounds. This became unacceptable, uncouth, and had acoustical limitations as well. I'd like to digress briefly to go over some features of our modern stethoscopes. There are several different types of stethoscopes. This is the most common one, probably the most common one that you're likely to have. There are several different parts of the stethoscope here. The first that I'm holding up is the earpiece, which obviously goes in your ear and around your neck. The second is the tubing, which connects the earpiece to the all-important head, which is the part of the stethoscope that we listen on the body with. You'll notice that the head of a stethoscope has two different sides on it that look differently. There's a large side that has a plastic covering on it, and we refer to that as the diaphragm. And then there's another side that looks somewhat hollowed out that has a hole in the center of it, but no plastic covering, and we call that the bell. When we're listening to the lung, we use the diaphragm side, which is generally better to hear high-pitched sounds. The bell is used in the cardiac exam at certain points, and it picks up low-frequency sounds better. Usually the diaphragm is placed on the chest mildly firmly, and the bell is placed on the chest very lightly. You can actually switch from diaphragm function to bell function by turning the head until it clicks, and you could get the bell. You'll know that it's on the bell when the hole in the center is actually open. You'll also notice here that the earpieces come off at an angle from the tubing. When we put the stethoscope in, we make use of that angle and put it in so that the earpieces are actually oriented facing forward, which matches the natural trajectory of our ear canals in a forward-facing position. There is another common stethoscope out there that you'll see, and you may even have to use someday. And this is a stethoscope that only has a single type of head. These are sometimes called floating diaphragm stethoscopes. They can also be called tuning stethoscopes. In these stethoscopes, you don't have to turn the head at all to get the different diaphragm or bell function. If you place the stethoscope on the chest firmly, it functions like a diaphragm by stretching the plastic piece out. If you place it on the chest lightly, it's actually functioning more like the bell, picking up low-frequency sounds. One final but very, very important point before we begin auscultating. The pulmonary exam should be done, ideally, on bare skin, with the thorax exposed. There are several reasons for this. Number one, some breath sounds are quite soft and/or subtle. Layers of clothing can muffle or block sounds from being heard. Number two, Sometimes clothing itself can create abnormal sounds as the chest expands. We don't want to misinterpret these as abnormal lung sounds. Number 3, sometimes we find things on the chest wall that can be very important. For example, the melanoma in the picture on the right, or the shingles in the picture on the left. There are, of course, situations in which it is not possible or it is unacceptable to expose a patient's chest. For example, if you are in a place where you have to examine patients in a public or less than private area. There are a few other situations in which it can be very hard to get down to the skin. However, most of the time you should either have the patient in a medical gown or loosen and move clothing in such a way as to expose the skin. As I've said earlier, we're going to use the diaphragm or the diaphragm function of our stethoscope. Make sure the stethoscope is not too cold. Instruct the patient to breathe both ways with his or her mouth open, deeply or deeper than usual. As the patient is breathing, you're going to move your stethoscope from side to side in the 3 spots that you see here. These spots correspond to the upper lobe, the upper part of the lower lobe, and the lower part of the lower lobe that we saw earlier in our surface anatomy slides. Then we move around to the front, again listening side to side in the following 3 spots that you can see here. Once again, anatomically, these are corresponding to the upper lobe, the middle lobe on the right, and an area of the left that we refer to as the lingula, and then the area where the lower lobes were projecting forward. Be careful. Breathing deeply so many times can cause the patient to hyperventilate, and it's wise to take a short break before moving from the back to the front so that the patient doesn't end up hyperventilating. Let's listen to some lung sounds. Let's start with normal breath sounds. The normal breath sounds, which are the predominant sound that you should hear in most areas of the chest, are 1. Not too loud, 2. Generally low-pitched, and 3. Louder during inspiration than in expiration. In fact, the normal breath sounds often disappear during expiration at some point. For historical anatomical reasons, we call these vesicular breath sounds. This is, as I've said, the most common breath sounds that you should hear in all lung fields. In fact, another thing that we are checking for is whether there actually are breath sounds at all in all of the lung areas and whether the sounds are symmetric with the other side. There are some lung and pleural conditions in which breath sounds may be quite muffled or absent in a particular area of the lungs. Lastly, note that for younger patients and thinner patients, the normal breath sounds may be, in general, louder, slightly higher in pitch, and go deeper into expiration. But for most people, the description of the sounds is as I've noted. What are some of the abnormal sounds that we might hear? I've already mentioned the possibility of greatly reduced or even absent breath sounds in a particular area. This can be very significant and point to a problem in or around that part of the lung. Another abnormal sound is a wheeze. Let's listen to wheezes. This is a musical type sound, continuous for a short time and with a pitch to it. This sound can signify narrowed or obstructed airways, as occurs in asthma. The air moving through and vibrating the narrowed airways mimics a woodwind instrument and produces this sound. There are also sounds called crackles. These sound like Velcro, or like rubbing your hair between your fingers next to your ear. We believe that this sound occurs when small airways, or alveoli that are filled with fluid, inflammation, or scar tissue, pop open, thus creating this staticky, discontinuous sound. Lastly, stridor is a harsh and sometimes alarming sound that occurs when there is an obstruction of the upper airway. It is present and louder during inspiration. There are other sounds which you will learn about in the future. What other techniques and/or maneuvers can we do to ascertain problems in the lung, or to reassure us that the lungs are okay? What if there are abnormalities that we detect on auscultation? The next most commonly used procedure, and this is included in the core physical exam of the lungs, is percussion. Percussion, as you might expect from the name, is a technique of hammering with our fingers onto the chest wall overlying the lungs to detect the normal hollow sound and feel of an air-filled structure beneath our finger. It can be likened to the process of trying to find studs and beams behind a wall when you are trying to hang something on the wall. The hollow sound and feel when we tap on an air-filled chest is called resonance. I'm going to demonstrate percussion on a patient now. Place the third finger of your non-dominant hand firmly on the chest and try only to get the very distal portion of the finger on the chest, removing all your other fingers and your hand from the chest. Push fairly firmly. Then, using your dominant hand, usually your third finger, but some people use 2 fingers to do this, you hammer on to that finger, bouncing off quickly in a striking type of motion. It does help to push forcefully on the chest with this finger, and it also helps to get the other parts of the hand and fingers off the chest so that it doesn't dampen the sound. We percuss in the following 3 locations, in the same stepwise sequence that we used for auscultation. If you are practicing on yourself, you can percuss over your anterior chest below the clavicles. This should be resonant. Try then doing it on your thigh, which is, of course, not air-filled. This should feel and sound dull. All parts of the lungs are filled with air, even after exhaling, and so should be resonant. If one part of the lung sounds and feels dull, it could mean that there is fluid or inflammation in or around the lung in that area, or perhaps even a large solid mass. There are a few more techniques that can be done. Generally, these are done less frequently and only when the situation or a previously detected abnormality suggests a problem. Tactile fremitus is a technique of detecting vibrations on the chest that are made by the patient's spoken voice, which are transmitted through the airways and lung tissues to the chest wall. We place a portion of our hands on the chest wall in symmetric locations and ask the patient to say the word 99 repeatedly as we move our hands symmetrically to new locations. So for this, we try to detect vibrations with a limited part of our hand, and we put them on symmetrically. So arch your hands back and try to get as little of your hand as possible on the chest firmly, like so.
99.
Okay, I'm going to check for some vibrations on your chest. And when I put my hands on your chest, I want you to say the words 99.
Okay.
And then I'll move my hands around and keep saying 99.
Okay. 99. 99. 99.
If the airways, lungs, and pleural spaces are all normal, air-filled, and unobstructed, we should feel light vibrations in our hands. On the other hand, if there is fluid in the pleural space or a mass blocking an airway, we will not feel a vibration on that side. The most common test of vocal resonance is the test for egophony, also known as E to A change. Okay, I'm going to put my stethoscope on and I'm going to ask you to say the letter E in a prolonged way, like E, and as I move the stethoscope around, say E again.
Okay. E, 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 E.
If the patient's lung is normal, and you listen over the chest with your stethoscope while the patient is saying out loud, E, you will hear a muffled version of the E sound. If, however, there is an area of the lung with inflammation and pus in it, pneumonia, for example, the tone of the sound will be altered into an A tone. It is often clearer and a bit louder as well. This is called egophony and is mostly useful in cases of pneumonia. Likewise, another similar test is called whispered pectoriloquy. In this case, you listen over the chest in all of the auscultation areas and ask the patient to whisper softly 1, 2, 3. Okay, so I'm going to ask you to whisper 1, 2, 3 in a very soft whisper as I move my stethoscope around.
Okay. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3.
Normally, the whispered voice is transmitted poorly through the lung, and you will only hear a very indistinct and soft sound. However, if inflammation or consolidation is present, the sound of the 1, 2, 3 will be amplified and will sound very clear. Again, like egophony, this would signify consolidation of the lung, which is the word we use to describe inflammation, often with pus, in the lungs. What information should you have at the end of your pulmonary exam? First, is the patient's work of breathing normal or abnormal? Is there any respiratory distress, for example? Second, are there normal breath sounds heard symmetrically and in all areas of the lungs? Third, are there any abnormal sounds? We often refer to these as adventitial sounds, such as wheezes or crackles. And lastly, if there are abnormalities of any of the above, where are they, broadly speaking, in the lung, using our knowledge of surface anatomy? What are some of the mistakes that we may make when doing the pulmonary exam? First, not examining enough areas or locations. In the hospital, for example, with patients lying in bed, we may listen to a few spots anteriorly only. Sometimes when we're in the office, we only listen posteriorly. Second, not exposing the thorax down to the skin and examining on the skin, which can be problematic for the reasons that I listed earlier. Next, not waiting for full expiration before moving our stethoscope to the next spot when auscultating. Some abnormal sounds, particularly wheezes, can be present only very late in expiration, and we may miss these if we're not patient. If you are doing a complete exam, be careful not to hyperventilate the patient. Take a 10 or 15 second break after 6 breaths or so. If you do detect something abnormal, go back and check it again to confirm. And lastly, don't forget that some of the specialized tests that I reviewed toward the end, though not used often, can and should be used if there are abnormalities or if a high index of suspicion is present that there is a pulmonary problem. Here are some of the terms that we use when documenting a normal pulmonary exam. I've referred to some or most of these previously. In the future, when you are doing write-ups and oral presentations, these are some of the phrases and terms that you will use when documenting the pulmonary examination. I hope this video has given you an understanding of the pulmonary exam. Soon you'll be using this on real patients and on patient instructors. Thank you for watching.